Welcome everyone to the May prevention session of the VLC, removing restrictions on access to hepatitis treatment, made possible in partnership with the CDC's Division of Viral Hepatitis. My name is Isabella Chuga. I use she, aya pronouns, and I am a senior manager on the hepatitis team at NASDAD. I am joined today by the moderator of this session, Lindsey Sizemore, Viral Hepatitis Program Director at the Tennessee Department of Health and a NASDAD Heptat Consultant, who is joined by our presenters for this session, Dr. Adrienne Simmons Rivera, Director of Programs, National Viral Hepatitis Roundtable, Suzanne Davies, Attorney and Clinical Fellow at the Center for Health Law and Policy Innovation of Harvard Law School, and Josh Swatek, Hepatitis and Harm Reduction Program Manager with the New Mexico Department of Health. So today we will begin our session with presentations by Adrienne and Suzanne, and then Josh, followed by discussion and Q&A led by Lindsey. Feel free to use the chat box to introduce yourself and jurisdiction and to ask questions. And with that, I'll turn it over to Adrienne and Suzanne.
Awesome. Thanks so much, Isabel. I'm going to go ahead and share my screen and we will dive right in. All right. Well, thank you for that introduction and for the opportunity to present today. As Isabel mentioned, my name is Adrienne Simmons, and I'm joined today by my colleague, Suzanne Davies. Today, we're going to be presenting on hepatitis C treatment access in state Medicaid programs. The plan for the next 20 so minutes together is to provide an overview of a 5-year project that the National Viral Hepatitis Roundtable, as well as the Center for Health Law and Policy Innovation at Harvard Law School, have been partnering on called Hepatitis C State of Medicaid Access. You may also have heard this referred to as State of Hep C. We'll pop a link to the website in the chat. But really the lay of today's presentation is to review what the project is and the recent progress that we've made, as well as the current state of hepatitis C treatment access in state Medicaid programs, to discuss remaining barriers to care, and then we'll wrap up by sharing what's coming next for the State of Hep C project. Suzanne's going to kick things off with a history of hepatitis C treatment access and an overview of the project.
Thanks, Adrienne. Hi, everyone. I'm Suzanne. I'm just going to give you all a brief overview to start of the history of HCV treatment access in Medicaid. In 2013, the FDA first approved direct-acting antivirals to treat hepatitis C. And initially, many payers imposed strict restrictions on access. In 2014, CHILPI partnered with academic researchers at Brown University, the University of New South Wales, and the Treatment Action Group to conduct a state-by-state survey of treatment access restrictions to DAAs and Medicaid programs. And this initial review showed that there was widespread restrictions across the country, as well as widespread transparency issues, because at the time, many states didn't publish their policies or didn't publish them in full. In 2015, in response to advocacy about treatment access issues, CMS issued guidance to states that Medicaid must cover medically necessary DAA treatments. In 2016, CHILPI brought a winning lawsuit against Washington Medicaid for its policy requiring severe liver damage before treatment. As a result of the lawsuit, Washington Medicaid changed its policy, expanding access to treatment in that state. And in 2017, NVHR and CHILPI launched Hepatitis C State of Medicaid Access, which tracks Medicaid restrictions in each state. Next slide, please. Next slide, please. Hepatitis C State of Medicaid Access documents the current state of Medicaid HCV treatment across 52 jurisdictions, including individual state-by-state report cards that grade and evaluate specific treatment access barriers. Our findings are based on surveys of Medicaid officials, publicly available documents, including clinical criteria and prior authorization forms, and official press or media releases put out by state Medicaid programs. Next slide, please. Since 2017, our project has tracked 3 main barriers to treatment. And those barriers are restrictions that are based on liver damage, measured by fibrosis score, restrictions based on sobriety, which could look like denying treatment unless a person has been abstinent from drugs or alcohol for a certain number of months, or restrictions that require a person to enroll in substance use counseling prior to or during treatment. And finally, prescriber restrictions, which say that only certain types of healthcare providers, like a hepatologist or an infectious disease specialist, can prescribe treatment, or requiring that prescriptions be made in consultation with those types of specialists. Next slide, please. Now that I've laid out the three major barriers to access that we track, I want to take a step back and return to the litigation that I mentioned in an earlier slide. In 2016, Chilpy brought a case in federal court against Washington Medicaid to end its policy of denying DAA treatment on the basis of fibrosis score. And this was the first of several cases, some of them brought by Chilpy and some of them brought by others, that helped expand access to treatment in state Medicaids across the country. Since 2016, Chilpy has continued its litigation campaign. By way of example, last year in 2021, we settled a lawsuit with Texas Medicaid, with the result that Texas Medicaid eliminated its fibrosis, sobriety, and prescriber restrictions. More recently, this week, in partnership with AIDS Alabama, Chilpy filed an administrative complaint with the Department of Justice against Alabama Medicaid, arguing that Alabama Medicaid's sobriety policy, which denies treatment to anyone who has used drugs or alcohol within the last 6 months, violates the Americans with Disabilities Act. Since 2016, courts across the country have found that many of the restrictions placed on access to DAAs, like fibrosis score or sobriety restrictions, are illegal. The court opinions, settlement agreements, and policy changes that result from these cases can also be a valuable tool to help advocate for change in other states. Next slide. You're muted, Adrienne.
Thanks, Suzanne. After 2 years, we would think that we'd have this figured out. Thanks for that overview. We're now going to transition into talking a little bit about what recent progress we've made as it relates to removing barriers to care and prior authorization restrictions in state Medicaid programs before talking about where there's more work to be done. And so to start, shown here on the screen is a map that you'll find on the homepage of our website, www.stateofhepc.org. And this map depicts the severity of hepatitis C treatment policies in Medicaid programs across the country. And so just at a quick glance, you can see that the lighter states have less restrictions in place, while the darker states have more restrictions in place. You can also see that there are a number of states that are colored in gray. And so those states have removed prior authorization to some degree over the course of the last couple of years. At a glance, you can see that there continues to be really severe restrictions in states that have been hard hit by the hepatitis C and overdose pandemic. Just to name a couple, you can see very clearly that in the South, there still remain pretty severe restrictions to hepatitis C treatment. We'll now review the state policies in more detail, starting with the use of prior authorizations. And so excitedly, a total of 12 states now allow access to hepatitis C treatment without requiring prior authorization for most patients. Those states include Washington, Louisiana, New York, California, Indiana, Wisconsin, Missouri, Michigan, Rhode Island, Virginia, Alaska, and Massachusetts. Oregon will soon be the 13th state to join this list. The majority of these states removed prior authorization without using an innovative payment model. You may also have heard that referred to as a subscription model or a Netflix model. This is a tremendous improvement that will help streamline access to treatment by eliminating burdensome paperwork. So we're really excited to see that a number of states continue to make great progress by removing prior authorizations. Suzanne talked about the three main criteria that we track being liver damage, sobriety requirements, and prescriber requirements. And so first we'll walk through the progress that we've made since 2014 as it relates to liver damage. We've seen the most progress made to date in removing this barrier. And so 33 states have either eliminated or reduced their fibrosis restrictions, and only 2 states still have restrictions remaining. Those states are South Dakota and Arkansas. And so when you, at a quick glance, you can look at the map on the left that shows the prevalence of fibrosis restrictions in 2014. And you can see that there were a number of states that imposed a minimum level of liver damage in order to access treatment. But we've made significant progress in large part due to litigation around this restriction. Now we'll discuss substance use related or sobriety restrictions. Suzanne mentioned that historically, many states have required patients to abstain from substances for a specific period of time in order to receive hepatitis C treatment. Despite despite injection drug use being the driver of new infections. Fortunately, we have seen that 29 states have loosened their sobriety restrictions, and the majority of states no longer require a minimum period of abstinence. While we've seen improvements in restrictions related to substance use, this remains the most widespread barrier of the barriers that we currently track. And so again, looking at the map on the left in 2014, you can see that there's a lot of dark red on the screen, which shows that a number of states imposed very severe restrictions as it related to substance use. On the right-hand side, while we see less red, we still see that there are a number of states that require a minimum period of abstinence from drug use. And so again, we are hopeful that we'll continue to make progress in this area, and certainly think that the complaint that's been filed in Alabama will help us do that. And then finally, we'll review prescriber restrictions. Again, we've seen important improvements in prescriber restrictions, but barriers still remain. And so 18 states require a specialist to be involved in prescribing hepatitis C treatment, whether that's either, even if that's only just a consultative relationship. We have one state that still requires that the prescriptions actually be written by a specialist. So it's not enough to just have a relationship with a specialist that might review a patient's prescription, but the prescription actually has to be written by the specialist. This is particularly a barrier in areas where there aren't many specialists available. Thinking about rural areas, this certainly presents a problem. Using West Virginia as an example, there is only one hepatologist, the last I've heard, in the entire state. And this is a state that, again, has been hard hit by the hepatitis C and opioid crisis. And they have a specialist requirement in place that, again, requires primary care providers to have some sort of relationship with a hepatologist or an infectious disease specialist in order to prescribe treatment. I'm now going to turn it over to Suzanne to discuss additional barriers to care.
Thanks, Adrienne. So one of the things that we've noticed in the process of tracking these individual state-by-state barriers is that there are, of course, a number of barriers in addition to the three big ones: fibrosis, sobriety, and prescriber restrictions. And as those barriers have started to go away in many states, we're turning our attention to the barriers that still remain that restrict access to care in other ways. So in spring 2022, our project team, as part of the next step forward, solicited input from stakeholders on ways that we could improve how we track and report on treatment access in state Medicaid programs by including some of those additional barriers that we hadn't officially tracked in the past. To that end, we held a public listening session, convened a provider steering committee, and put out a public survey. Next slide, please. Our survey reached 275 respondents from 43 different states and included advocates, clinical providers, government staff, people with lived experience, and pharmaceutical company staff. Next slide, please. Up on the screen, you can see a list of 8 additional barriers to care that we identified through this process, compared to just 4 barriers that had previously been tracked in the current iteration of the report cards. And I should mention the 4th barrier is parity issues in managed care organizations, where sometimes they don't have the exact same requirements as the fee-for-service does. The barriers that we've identified that are up on the screen are prior authorization as a process barrier, requirements that someone submit a chronic infection diagnosis as opposed to simply being diagnosed with hepatitis C, time-based laboratory values, so requirements that people submit, for example, lab results that is from within the last 3 months and rejecting that person if the lab result is too old, requirements that genotype be documented, assessments of adherence, restrictions on retreatment for people who are infected more than once and may need to be treated again, restrictions based around specialty pharmacy and mail order requirements, and restrictions that come up around different criteria for preferred regimens versus non-preferred regimens. Next slide, please. I'm going to pass it over to Adrienne now to talk about the impact of these specific barriers on patients who are seeking care.
Thanks, Suzanne. So you might be wondering, what's the impact of these barriers? Why do we continue to push for the removal of restrictions and ultimately the removal of prior authorizations? Well, we've heard anecdotally and objectively that these barriers result in delays, denials, and interruptions to care. And this ultimately impedes our ability to eliminate hepatitis C by 2030, particularly among communities who are disproportionately impacted by hepatitis C. A paper in Rhode Island estimated that prior authorization takes somewhere between 45 to 120 minutes per patient. So 1 to 2 hours per patient. And that doesn't include the time that's spent addressing denials and appeals. Patients are frequently lost to follow-up due to these administrative barriers at every step of the way. We'd like to share a few quotes with you from our survey that describe the impact of these barriers. One provider who responded to our survey said that in my state, there's actually investigation into adherence for other medications for the patient. For instance, if a person has picked up their diabetes medications late before, Medicaid will deny their hepatitis C treatment. Another respondent said, the burdens include the wasteful cost of repeat labs and the negative impact on patients regarding costs and access to transportation. Genotype results have a long turnaround time, sometimes creating delays. And then finally, some of the specialty pharmacies have requirements to speak with the patient before mailing the medication. It becomes a barrier and possibly even a delay in treatment. The impact of these barriers is also evident in the data recently published by CDC, which showed that the number of people who initiated treatment declined from 2015 to 2020. The National Academies of Science, Engineering, and Medicine estimated that at least 260,000 people must be treated each year to eliminate hepatitis C by 2030. However, on average, only 120,000 people are treated each year, and that number continues to decline in the context of the COVID-19 pandemic. I'll pass it to Suzanne once more to close us out.
Thanks, Adrienne. Next slide, please. Our next steps for this project are pretty straightforward. After we received stakeholder feedback in February and March, we spent April and the beginning of May engaged in data collection, which we're wrapping up this week. And we're now analyzing the data that we found and using it to update our newly revamped report cards with a new rubric that reflects some of the restrictions that we've talked about today. And we have a full release of the updated version of the project planned for June 2022. Our update is going to include a formal report that analyzes our findings, as well as the individual state-by-state report cards and grades that we've mentioned previously. It's our hope that the relaunch of this project with new information will help expand treatment access in every state. Next slide, please. This brings us to the end of our presentation. We welcome your questions about the project, whether that's during the Q&A today or later via email. And our contact info is up on the slide, as well as the names of our project team members who aren't presenting today, Julia Harvey, Daniel Raymond, and Robert Greenwald. Thanks so much for listening.
Hey, good afternoon, everyone. I'll go ahead and share my slides now. Give me just 1 second. All right. So I'm just going to briefly talk about an update here in New Mexico about what's going on with hepatitis C. And we'll focus mainly on health systems and Medicaid, since that's what we're talking about today. But really, these are more to keep me on track. And if you have questions, feel free to ask. So these are the 5 main strengths or areas that New Mexico has been working on with regards to HCV elimination and really working on addressing viral hepatitis in New Mexico. So obviously, New Mexico has Project ECHO. It was founded in New Mexico because of hepatitis C. Dr. Rivera is a gastroenterologist that used to treat folks with interferon and teach primary care providers how to treat hepatitis C. A fun little fact, a lot of people don't know, the little C there in Project ECHO is actually a callback to the origins of the program. So this has been really helpful. This has been able to train providers all across the state, especially now that we're working with DAAs. It's really easy. And so when we do get complicated cases, folks that are or treatment experience, or have more advanced liver disease, primary care can present those here in New Mexico. Another great thing, and we'll talk about corrections here in just a moment, is the peer education project that we have here. This is a really great thing for states. We've been able to educate folks in correctional settings, as we know, viral hepatitis has a higher rate in those areas, about the treatment. And we found that's really important because we have a lot of individuals that are out there that really think that the old treatments are still around, right? That they're really nasty treatments, and they don't want to take it. They don't feel bad. Why get treated? These are individuals that we can teach, to how to teach their peers about not just hepatitis C, but other health messaging, harm reduction messaging. I was actually on COVID education. I did several on those because that was my assignment for that period of time. So these are really great folks that are really trying to make their current living environment a more healthy place. So it's a really good model to practice. And if you're interested, I can link you up with the folks that do that. So again, on a related note on corrections. So we've had universal antibody screening for a long time, and we have very high rates, as I had mentioned. 45 to 50% individuals are antibody positive. And in 2019, we got basically a good deal on confirmatory labs and added that because that's really the information that we want to know. Do you currently have hepatitis C? So as of 2019, everyone upon entrance gets a screen for hepatitis C with an automatic reflex to an RNA test. Just recently, last year, they started doing upon exit too, because we know that individuals do acquire hepatitis C in correctional settings, and we want them to know their status and be able to be linked with care afterwards if they happen to acquire it while they're in one of the correctional facilities. So utilizing all this data, the large number of folks, we were able to get an allocation of about $20 million from our state legislator to cure an estimated about 2,800 people over the next 5 years. So it's a phased-in approach. We can't treat everyone that has hepatitis C all at once in New Mexico corrections because A, the demand isn't quite there yet because we're still doing a lot of education, and B, we lack a lot of providers. So we have this phased-in approach like Medicaid did in the beginning, where the folks with more advanced disease, they'll be treated first. Right now, I think it's pretty much, it's actually pretty much open to anyone who wants to get treated in state corrections. So this is really, really good thing. And as I mentioned, the peer education program, they're educating individuals on screening and treatment for hepatitis C. This is really, really important for our programs to succeed. And it's important to treat corrections as its sort of own health system because it does operate, it operates alongside but outside of our traditional health systems. And there's a lot of risk factors there. So it's a great place to get a lot of folks treated. So here talking about our Medicaid here in New Mexico. So our restrictions started to get removed about 2015. Again, that was a phased-in approach. We decided to treat individuals in a fiscally responsible manner as a state because there was this idea that there was a lot of warehousing of patients. People were just holding on to patients, waiting for the DAAs to get treated, and there was going to be this massive flood of patients coming in. And that would actually bankrupt state Medicaid. That was the real concern. And I'll show you here in a couple of slides why that wasn't really the case. We immediately got rid of access to treatment for sobriety and specialist requirements. That was the first thing we did. And then by 2016, we removed all fibrosis score restrictions. We find here in New Mexico that the people who treat the most hepatitis C here are definitely not specialists. They're nurse practitioners and PAs in fairly qualified health centers and prisons and soon in public health offices here in New Mexico. All the MCOs have HCV care coordinators because they're really heavily incentivized to meet their goals. So every managed care organization has a goal that's set out by Medicaid. If they don't reach it, they don't make their incentives. They also have incentives for providers. So the providers themselves, they're paid extra to be treating people for hepatitis C. This was brought about because Medicaid, the MCOs, weren't really meeting their target numbers. So that expectation of the flood of patients coming in and bankrupting just wasn't a reality here in New Mexico. And I'll show you that here so far. So far, this is through 2014 to 2020. Sorry, I couldn't get 21 data. I was trying to, but our folks are a little bit busy dealing with the fires that we have up north here in New Mexico right now. So apologies for that. But what we have here is 6,578 people who have been treated for hepatitis C, and only about 4% of those individuals were treated more than once. So there's that concern of, oh, you're going to retreat the same people over and over again. That's not really the case. And I'll be honest, most of these, I haven't looked into the data too much, but I'm guessing it's usually folks that either dropped off, moved, or were incarcerated for a period of time, so their prescription lapsed rather than a reinfection. But as you see here, so 2016, that was the year that we really opened up treatment for everyone. We only had 945 people. I think our goals are around 1,800. So we've never actually really met those with all the requirements, that were all the things that we're pushing out, provider incentives. Some of our managed care organizations are doing patient incentives. They're paying patients to get treated. So even with all that, we're seeing lower numbers. We boosted up there with the provider incentive. We kind of dropped in 2020. I think we all know why. But there's not this rush for treatment. It's not going to bankrupt the state. I think that much is very clear. And the benefit is there, obviously. I don't need to tell everyone here for what the benefit of treating folks early is. So another real big aspect that we have here in New Mexico, we still have a high risk pool, and hepatitis C is a qualifying condition for that. So if you have hepatitis C in New Mexico and you're categorically ineligible for insurance, so you either recent immigrant, undocumented, someone that even missed open enrollment for your job or for ACA, you don't have insurance for whatever reason and you can't get it, we will actually pay for your premiums and your co-pays to be able to get treated as long as you go through one of our providers. We're able to do this because we access 340B pricing, and we have a contract pharmacy, so the department can actually pay those premiums and co-pays. And then the revenue that we get, this is full insurance, we put back into the program and back to the programs to get people to come in and get treated. It's Hep C case management, basically. So that's something that we're really excited about. Pandemic has delayed us quite a bit in getting that started, but we're also going to, through this, be able to provide safety net options through the health offices that we have here. So this is an option for folks who might not be insured. And of course, comprehensive harm reduction services. I've talked about this quite a bit. We have a large percentage of folks that we've been able to reach through harm reduction. It's a key component of us, for component 3, which is great, that we're able to expand some of those hepatitis C efforts in harm reduction settings here in New Mexico. We did a point in time survey a number of years back, and 87% said they, oh yeah, we've been tested for hepatitis C. So testing's not the issue here. We found that out, but only 24% have been initiated for treatment. And when we went out and we asked people, well, why not? Like, oh, I don't want to take interferon. I feel fine. The treatment's nasty. So that's our goal. That's our goal, is educating people about the new treatment and where to find it and how to obtain it. And a lot of our harm reduction providers are also federally qualified health centers. We have partnerships with different clinics, to really provide culturally appropriate treatment for folks. And again, since we have that expanded Medicaid, we have no restrictions on sobriety. We're able to treat those folks more readily. I would be remiss to not mention our recent bill that allowed for harm reduction to provide additional items. So snorting and smoking supplies. And I think we're seeing this trend all across the country where individuals are switching to smoking, and we have a lot of harm reduction program participants who want to switch to smoking but don't have the supplies. We're able to make that change here. And as we all know, that greatly reduces your risk of viral hepatitis transmission. So that's a key component to harm reduction policy. So really, how did we all do this? So first of all, we're lucky here. If you're from a small state, you have access, right? Everyone knows each other in a smaller state, so it might be easier to find the key players, just to reach out and talk to them. So that's something I would highly recommend if you're in a small to moderate sized state, is use your personal contact list. We were able to bring several cabinet agencies together under our previous administration to begin this. So we had state government, we had Department of Health, we had corrections, all coming together to go ahead and make this a moral imperative, to make sure that the citizens of New Mexico were treated for hepatitis C. Our program, in collaboration with Project ECHO, really took lead on this. We reached out to individuals. Sorry about that. All right. So, lovely working from home with dogs. All right. My apologies. So we reached out to agencies across the state.
I'm going to interrupt just for a second. I think this is a great space to let everyone know that Josh and I went to high school together. And I am so happy to see him thriving. Go for it, Josh.
Yeah, sorry about that. It's politician season and they've been knocking on my door. So my dogs really don't like that. So my apologies, everyone. Another great thing that we were able to do is, so there was those legal challenges, as were mentioned. Those are really great opportunities to convince the policymakers to go ahead and make those decisions, because it's always much cheaper and fiscally responsible for a state government to get ahead of it and show that you're doing something, as opposed to being forced to do it. So that's something that we're talking to policymakers who aren't really in favor of, opening treatment, who might not feel about, everyone having access like we all do, is that it's going to be cheaper, right? It's going to affect the state's bottom line, and pointing out these legal challenges where the states have lost and saying it's going to happen anyways, we might as well just do it now, is effective for a certain demographic of decision makers. And the last piece there that I really want to mention is actually, don't be afraid to cold call people. So I was we were talking about this panel previously. I said, one of the biggest things that when I was a hepatitis coordinator that I didn't realize is that I was going to be a salesperson. I was going to be cold calling people, making relationships, doing all these things that I did when I had a sales job back in college, that that was useful for me, because it's really about making those connections and making, being able to have those one-on-one conversations, to be able to convince people that this is really important, and these policy decisions, these policy changes can make a huge impact with not a lot of fiscal, with not a lot of extra fiscal, issues that come down. It's actually fiscally responsible to do so if you look at, all the models when you're talking about treating hepatitis. So that's a great thing. And, I also making friends with your state legislator, your own personal legislator. I know we're all, we have various restrictions on how we can talk to policymakers at the state level, but you're all individuals too. So be an individual advocate for all of these, changes to Medicaid, corrections. Reach out to the people that make those decisions. Reach out to your, state senators, state representatives, and reach out as a person. So that's, my little call to everyone is just don't just do it just in your job if you're able to. Do it as a private citizen. So that's something I've done myself, and it's helped. I've gotten to know quite a few. So when I do come back to them in an official capacity, they're much more willing to talk to me, or at least they're more briefed on the issue. And this is just one of our little campaigns that we had. It's part of a larger campaign. It's called our Think campaign. We did, Think testing, Think syphilis. This is our Think cure. Again, part of getting that message out to treat hepatitis C. This is a few years old. We're working on updating graphics and getting, better messaging out there. But just want to use this as an example of, these are things that we can hang out up in public health offices, harm reduction. We put these in big poster size and little card sizes and kind of handed them out to a bunch of people just to get a brief word out there about thinking about getting cured for hepatitis C and where to find some of those, ways to get supported. So I'd also like to acknowledge some of the folks that actually went before me that made this job easier. Lane Snow, Andrew Dans, and Andrew Knox, they all working together at the program. I know also Amy Drake's on here. I saw her. She's worked in epidemiology for us. So yeah, so thank you, everyone.
Great, thank you. Can somebody confirm that you can hear me?
Yes.
Great, awesome. So now we're going to start our discussion and Q&A, which is very exciting. So I have been monitoring the chat, and there were quite a few questions that came through. So first of all, I want to say there was lots of love in the chat. Great presentations all around, Adrienne, Suzanne, and Josh. And also, Josh, just FYI, there was a request to see your dog. So if that's feasible at some point, just know that that has been requested.
I can do that.
Okay, great. All right, so jumping into the Q&A. So one question that came up was, can you speak to restrictions posed by private insurers? Not sure what portion of individuals needing Hep C treatment have Medicaid versus private insurance.
Yeah, I'm happy to take that question. And thanks for the question and for all of the love in the chat. Again, we really appreciate the opportunity to present and to share this information with you all. Obviously, the scope of this project has been state Medicaid programs, but certainly we get inquiries from folks all the time around private payers. I will say that to my knowledge, there has not been a recent analysis around the breakdown of hepatitis C prevalence by payer type. And obviously it wouldn't be very, as you all well know, wouldn't be very accurate given that our surveillance systems are so poor and we have not yet identified all of our infections. What I will say though is that at the end of the presentation, the CDC data that we referenced around treatment rates, I'll pop a link to that study in the chat. That does break down, at least based on pharmacy claims data over the last 6 or so years. That does break it down by payer, and it's 20% of those claims were Medicaid, 40% were commercial payers, and then 30% were Medicare. Over the last 5 or so years, we've seen an increase in the number of claims paid by Medicaid and a decrease in the number of claims paid by Medicare. So just to give you kind of like a snapshot of the people who have received treatment, how does that break down by payer type? In terms of the restrictions, we do anecdotally hear that restrictions are pretty prevalent among commercial insurers. And certainly we can see a little bit of that and make some extrapolations based on what we see in managed care organizations for state Medicaid programs. So obviously those organizations also have commercial. I don't know how I got automatically muted, but oftentimes when we see kind of discrepancies between the state Medicaid fee-for-service policy and the managed care organization policy, a lot of times the managed care policy aligns more with their commercial policy, has been my observation. And so we definitely see restrictions for private insurers. I think despite the CDC data showing that, only 20% of claims over the last 5 or 6 years have been Medicaid, I would venture to say that the majority of people that we have not identified probably have Medicaid. And so I would expect that number to be a lot higher. I'm a little surprised by the fact that commercial payers they're probably overrepresented in that data just based on us not doing a great job of identifying the communities that are most impacted. Hopefully that answers your question, but let me know if I didn't answer it.
Great, thank you. Okay, so the next question, really encouraging to learn about the New Mexico Peer Education Project. Has this model been replicated in other states? And so Isabel actually responded in the chat and said, last I checked about a dozen states. And so I just wanted to see if anyone had anything to add to that.
Yeah, I don't know specifically how many states. I do know. I mean, just from my personal experience, it was fantastic to work with all those folks. And it's, I mean, I can't support it enough. So it's a great resource, and it's pretty easy to replicate too. So
That was actually my question. Josh, could you speak to how that was initially implemented?
So that was really Echo, UNM Project Echo took the charge in that, and worked with our Secretary of Corrections at the time and said, hey, we would like to educate on not just hepatitis C, that was the goal originally, but other healthcare related things. And that includes behavioral health, substance use, substance use dependency. And the corrections secretary said, yeah, let's do it. So basically what they did is they went into the correctional settings, they recruited people, they said, hey, this is what we're doing. They did a series of training sessions. They do bi-monthly basically calls with all the peer educators across the state using Zoom platform, and talk about whatever the topics that folks are really concerned about in the correctional settings are. So
Great, thank you. Okay, so this one's a little longer, so if I need to repeat it, let me know. So this might be outside of the scope of this conversation, but I'd love to hear about how the need for this type of oversight came to be. I'm continuously surprised at how many state policies, like Medicaid, violate foundational policy like the ADA. Is there a plan in the future to build equity checks and ADA violation review, among other reviews, into the process of Medicaid health policy?
I think I'll probably have a very incomplete answer to that question. I think it's a great question. So I might say a couple things and then the other two of you can please chime in. My perception is that the ADA is really an underused statute. So to the extent that that anyone could bring a claim under the ADA against any policy, particularly in terms of healthcare and state Medicaid policies, it's happened occasionally in the past, but it's simply not, it's surprisingly underused. I think it would be great if there were checks in place. And one thing that I think might push us to get there would simply be more people bringing more claims, which would hopefully get the ball rolling on enforcement.
And I'll just add that it can also be really helpful for people to know that claims exist. And so, Suzanne mentioned that the Alabama complaint was just filed pretty recently, and that can be a really helpful tool, particularly in thinking about states that still have a mandatory period of abstinence. Certainly there's a whole spectrum of sobriety requirements, with that period of abstinence being the most stringent one. But if you're in a state that has that in place, you might consider reaching out to folks in Medicaid to say, hey, I just saw that this Alabama complaint, and we can put a link in the chat to it as well, just saw that this was filed in Alabama and we have a similar requirement. And that's regardless of the outcome, right? It can be helpful for people, just general awareness that this is happening and this is being investigated and followed up on, can sometimes be the push that states need.
Great, thank you. Okay, so this says, wow, fantastic work in New Mexico. Can you talk about how you were able to implement provider incentives for Hep C treatment in Medicaid?
money. I hate to say it. So the reason that the MCOs really did it, one of them did it on their own, but the reason they really did it is because they were incentivized by state Medicaid to meet their goals, and if they did not, they didn't make their incentive pay. So if you don't meet your goals, you don't get the extra money. And I mean, I hate to say it like that, but that's really what it made it across the board, that every MCO was offering providers, is that we weren't getting enough patients in, and they felt that more providers would help that. So they provided provider incentives. That's really what made that happen.
Speaking of
Josh.
things that are underutilized, I was just going to follow up to that. I think it's an interesting question, and maybe another thing that's underutilized is just quality measures for hepatitis C. And so I don't think that there has been kind of widespread use in the payer landscape around implementing quality measures for hepatitis C treatment, things like cure rates and the number of their members that has received treatment. And so that's not something that we've done any work around, but I think is always a question in the back of my mind as to whether there should be additional work in that area. And I certainly think goes hand in hand with the provider incentive piece.
Thank you both. Okay, so this question is also for Josh. So agree, really fantastic work in New Mexico. Does the New Mexico Medicaid insurance pool, I think that's what it stands for, the acronym, cover the cost of treatment or the other cost associated with receiving treatment, for example, labs?
So yeah, so it's the New Mexico Medical Insurance Pool. That's our Highrisk, what our Highrisk pool is called. It covers labs. It's full insurance. It covers everything. It acts like private insurance during that time. So it's actually a good time if someone has other co-occurring issues to get other things treated. If you have knee surgery you need, get that treated, right? It covers labs. The only issue that we had with that is that in order to be on it, you have to have confirmed hepatitis C diagnosis. So some of those folks with trying to get the labs were a little difficult. We just allowed folks to use our public health lab to be able to do that, to get that diagnosis. And then as soon as we get that diagnosis, we can get them in. It usually takes about 48 hours to get a claim or to get them registered, but we can do a rush in about 5 minutes if we have someone that's like right there that needs to be, and we have the labs already. So
that's fantastic. Okay, Josh, again for you. So many model programs to address barriers for people. Well done. Where do you see that gaps still exist?
So I think the biggest issue from our providers and just everyone across the board is specialty mail order pharmacies are the biggest issue. Is that, so MCOs, oh, you have to use our pharmacy, right? And you have to be mail out. Well, we can go to Walgreens down the street. The patient can go to Walgreens down the street. They have it in stock and they can get it right now. The second issue, and I think this is dealing with a lot more vulnerable folks, is when we're working with unhoused folks, where to keep their medication. That's something that we're trying to work with, because we all know bags are stolen, property's stolen, they're confiscated, it's lost. So really working on how do we ensure that folks can be in a situation where they can take their medication, adhere to it, and not have it disappear. So I think those are the two biggest barriers, other than the education piece that I already talked about, is educating folks that DAAs are not interferon. So
great. Okay, so this next question is kind of broad, but how time consuming are claims?
I mean, for us, it depends on the insurance type. I don't think they're overly burdensome here in New Mexico, but of course it could be improved. I don't know exactly. I'd have to ask our pharmacist how much time is going into it. But I don't think they're overly burdensome. Private insurance is probably a different issue, but I can't really speak to that since we don't have access to private insurance as much. So.
And Adrienne, did you want to weigh in?
I'm going to punt it to Suzanne, actually. Isabel, Suzanne, I think Isabel was interested in whether DOJ complaints are time consuming or not. So I will let you answer that.
Sorry, apparently we're all making this mistake today. I think once it's in the hands of the DOJ, it's sort of up to them about, first of all, whether they pursue any complaint that they receive, because of course they receive complaints from all over the country all the time, both from attorneys who have written up formal complaints, as we did, or from regular people who had something happen to them. So it's really unpredictable. I will say that there have been several really encouraging settlements recently made by the DOJ with various state entities, particularly nursing homes in various states where people had brought claims related to substance use disorder as the relevant disability. So we're really hopeful that this is something that the DOJ will take up and take seriously, but obviously I can't speak for them and I can't really predict what the timeline will be.
Thank you. Okay, so Josh, this is for you. Thanks for the answer on provider incentives. As a follow-up, how did you folks convince your Medicaid to include Hep C treatment as a quality metric? This is also from Thaddeus because Thaddeus also says hi.
Hey, Thaddeus. You know, really, that was a Medicaid thing. That just happened naturally. I think it's important to realize that here in New Mexico, we meet pretty consistently with our Medicaid folks. So DOH, Medicaid, ECHO, corrections, we talk, when we're doing our elimination planning monthly, and we have been for several years. So I think it really came naturally out of that planning process, is making sure having all those folks at the table. Then it's like, oh yeah, well, let's see if we can, let's see if we can use this to sort of, poke the MCOs to do a better job. So that's kind of how it was. I think it came out of our elimination planning, really.
Okay, thank you. So also, have you been able to partner with CBOs that have medical services or community clinics to set up medical lockers for patients?
She likes to say hi. This is my dog Monkey. She actually got named an honorary cabinet secretary during COVID. So, but to answer the question, yes, that's a possibility. The problem is, so we have a couple of places that do it, but it just gets so overwhelming. There's so much need and not enough folks that can provide that services. And it's actually a lot of resource intensive and space intensive. So, with the amount of need that we have, it costs a lot, oddly enough, just for rent space. So that's, yeah, you're totally right. Like that, we have a couple places that do it. We just need a whole lot more.
All right, so we have about 3 minutes left. So I'm actually going to take the liberty to ask a question because I don't see any more in the chat. So this is for Adrienne and Suzanne. What advocacy strategies have been helpful in removing prior authorization restrictions?
I can start out and feel free to chime in, Suzanne. We've talked a lot about how a combination of advocacy and litigation has really been what's moved the needle on this. I'll say that a couple of other things that we highlighted but didn't go into a ton of detail during the presentation are federal guidance is really helpful in this. And so in 2015, CMS issued federal guidance to state Medicaid programs, essentially saying that these restrictions were illegal and that they must provide medically necessary treatment. It did push some states to voluntarily remove these restrictions, but its guidance is only as good as its enforcement. And so it's certainly not the silver bullet. I think similarly, in terms of federal support, HHS convened the Hepatitis C affinity group for a number of years. I'm sure a lot of people on this call were a part of that in some capacity. And so that group has ended, but I do have heard anecdotally from coordinators that was an opportunity for states to get together. And oftentimes there were multiple representatives from your state, someone from DOH, someone from Medicaid, someone from corrections, to share information around these restrictions and how folks had made progress in removing them. And so I think it's really important to have a space like that and spaces like these in order for people to hear. Josh gave a great presentation about how in New Mexico, right, removing restrictions didn't open the floodgates and bankrupt Medicaid. And that's what we've seen in other states who have removed prior authorizations entirely. It's a little bit premature to look at the data at this point because there's always a lag in claims data. And a lot of these prior auth changes have happened during the pandemic. So there's also that confounder. But I do think that, a year from now, when we look back at that data, we're probably going to see that, again, it didn't open the floodgates because the reality is that you still got to find the people. Like opening access to treatment it's not the end all be all. And so federal guidance and support, whether that's in the form of issuing a bulletin or convening these affinity groups, has been really helpful. We talked about litigation. I'll spend just maybe a minute talking about advocacy strategies. Obviously we're advocates and we recognize that there are limitations from what coordinators and other state employees can engage in. So I appreciate, Josh, your comments around like you can still do things as a private citizen. So that's absolutely true. From our perspective, I would agree, Josh, it's really important to know who's making the decisions around these restrictions in your state. And so is it the Pharmacy and Therapeutics Committee or a Drug Utilization Review Board? Those committees are typically made up of pharmacists and physicians from the community. Many times those folks don't have experience with hepatitis C. And so a lot of these restrictions and decisions are being made from an uninformed standpoint. It's not necessarily malicious, but a little bit of education can go a long way. So it's important to know who those people are so that you can develop relationships with them. And then obviously building partnerships with your community, whether that's patients, providers, CBOs, so that you know who to reach out to when there are opportunities to push on these things. There's things like public comment, sending letters to Medicaid, requesting meetings with Medicaid. Those are extra effective when you have people that are actually impacted, included in those meetings. And oftentimes you all know who those people are. And if you don't know the patients, you know the providers because you may partner with them in other ways. So, just making them aware that like, hey, this is an opportunity for you to weigh in. Isn't necessarily you weighing in, but just providing information to people. So I guess long-winded way of saying you can always educate people and it may not be considered advocacy. So just think about how you can be creative in your role. Is there anything you'd like to add?
No, I completely agree with all of that.
Great, thank you so much. And thank you to all three of you for excellent presentations. Thank you to the attendees for being here today. I just wanted to remind everybody to complete the session evaluation survey via the link in the chat. And then one announcement is the VLC session scheduled for June 22nd has been moved up a week to June 15th. So mark your calendars and thanks everybody. Hope you have a great rest of the week.